We are going to start the afternoon session. The first afternoon session is called The Legal Framework for AI and Healthcare. And it will be moderated by Professor Elizabeth Pendo. Professor Pendo is a professor in the School of Law at St. Louis University. She's a nationally recognized expert in disability law, bioethics, and healthcare law and policy. She is the Joseph J. Simeone Professor of Law at St. Louis University School of Law and is a member of the Center for Health Law Studies, the William C. Wefel Center for Employment Law. Her scholarship advocates for greater access to adequate health care, work opportunities, integration in the community, and full participation in society with people for people with disabilities. And so, with no further ado, I welcome to the stage Professor Elizabeth Pendo.
Thank you so much for that introduction, and welcome back to the afternoon conference for today. We are shifting and looking at the legal framework that surrounds issues of AI, including in healthcare. And I'm very excited to be moderating a panel with 3 expert law professors who are going to talk to us about their work and share their insights about the governing structure of artificial intelligence and its multiple applications to the provision of healthcare services. All 3 of our speakers today are incredibly impressive. I'm going to keep the introductions brief so they have the most time to share their ideas and you have the most time to engage in conversation with them. We're going to follow a similar format as we did in the morning sessions. So I first want to introduce Nicholson Price. He's a professor of law at the University of Michigan School of Law, and the floor is yours.
Awesome. Yes, perfect. Fabulous. This is going to be slightly different because I don't really like slides. And the other challenge of speaking after a bunch of people have already spoken is that all the fun things that I wanted to say, well, not all the fun things, but a decent number of the fun things that I wanted to say, it turns out other people have already said because this is a cool conference and people are talking about interesting stuff. Also, I can't speak or think when standing or sitting still, so I will wander because that's just how I am. So what I want to talk about is a specific type of problem, the problem of contextual bias, issues that happen when you train AI in high-resource, fancy settings and then try to translate them into low-resource settings that are less fancy. And I want to talk about how the law helps create this problem and how the law can help us deal with this problem. But first I want to start with just a couple of prefatory notes, a little bit about scope. So when I think about how AI fits into the healthcare system, we've talked about some ways that it can, but I tend to group this into kind of 4 roles that it can fill in the health system, a couple of which we've heard about earlier today. So one of them is automating drudgery. All the stuff that everybody hates to do in the healthcare system, like the solution is let's have AI do it for us, which is great. Like take notes and pull out the relevant information and deal with things in patient records and electronic health records and all of those sorts of things. So automating drudgery. Optimizing resources, which is to say there's a scarce set of resources that are available for healthcare. Hopefully AI will create more resources, but there's still some scarcity. And so the question is, who needs this the most? Who would benefit from this the most? And AI can do that on the positive end. On the less positive end, we don't talk about this, but AI can also do interesting things about revenue maximization and patient selection and things like that. But we don't talk about that. And then on the care side, I think it's useful to divide how AI can help direct clinical care into 2 different kind of fundamental tasks. One of them, and this is the really sexy one, is pushing frontiers, which is to say AI can help us do things that we otherwise couldn't do. Look, we can figure out sepsis 48 hours, or kidney injury 48 hours before we see the symptoms. We can figure out sepsis 8 hours before we actually see the symptoms of sepsis. Here are things we could not do before, and now we can do them because AI is awesome. Or at least that's the dream. Like this is the headline, here's a super cool thing. And then what I think a ton of AI that's actually doing stuff on the clinical level now is democratizing expertise and saying, here's something that physicians and humans can already do. but we'd like to take the level of expertise that we find for really good physicians and make that available more broadly. So when we talk about the idea of saying in Nigeria there are 0.01 doctors for every 1,000 rural residents, and one way to try to help that is to say AI can help with that, we take some of the abilities that are otherwise limited to physicians and use AI to enable other people to do that, whether it's lay people taking on some physician tasks or primary care physicians taking on tasks of ophthalmologists or oncologists acting like they were really, really good oncologists as opposed to kind of middle-of-the-road oncologists. So democratizing expertise, I think, is a huge opportunity for AI, and that's actually what I'm going to be focusing on for most of the rest of the talk, which is the type of bias that can show up in this type of democratization. What happens when we try to implement AI outside the training system? But I also want to take as one more side note before I really dive into that. The idea that it's important to think that there are multiple different types of bias here. And in particular, one thing we've already heard about today is bias that's inherent in the health system, right? We had this Ziad, I always forget his name, Ziad Obermeyer, this paper that came out in Science last week about the algorithm that was used and used the metric of cost and ended up being hugely biased against African American patients. So we have evidence of things like African American children getting lower doses of pain medication when they have appendicitis than non-African American children. We have evidence about women getting differential diagnoses than men do, or missing symptoms of heart attack. All of these are biases that are inherent in the system and inherent in care. What I want to talk about is a type of bias that can arise even if there are no underlying biases. Even if we fix those issues, this is a set of issues that still arise when we try to take care from one system and generalize it to others. And so for the example I want to use for this is IBM Watson, which has, yes, lots of problems, but it's just such a good example of what we want to think about when we're thinking about democratizing care. Because the idea of Watson, right, is, at least their partnership with Memorial Sloan Kettering Watson for Oncology, is to say, look, here's a place with a bunch of really, really good world-class oncologists. But there aren't that many world-class oncologists. And so let's take a ton of data and let's train an algorithm on all of these patient data at Memorial Sloan Kettering, train it on what the oncologists there would do, and we'll take that expertise, we'll take that knowledge, we'll take those glorious patterns of perfect treatment, at least so the story goes, and we'll spread them out across the world because we'll have trained Watson to do this, and then you can take that and put that in hospitals in Mexico, in Thailand, in Florida, wherever you want, and it will take that superb care, we hope, and make that available to folks all around the world. And this, in fact, like generally put, is a more common model, or is a relatively common model, which is to say, academic medical centers are where a ton of AI gets trained, either at the academic medical center itself or on data from academic medical centers. And then the idea is that we'll take those high-quality trained algorithms and make them more widely available to democratize expertise. Sounds good. But I want to talk about why the law promotes this, or why the law at least creates additional incentives to do this, and then some of the problems that arise and how we might think about turning to the law to fix some of those problems. So why do we train in these types of settings? A couple sorts of answers. One of them is pretty simple. That's where the data are. Not all of the data, but if you're looking for data that have already been cleaned, that have gone through kind of de-identification procedures, that have gone through HIPAA review, that have gone through informed consent, that have gone through all of the barriers that law and ethics and other practices put up to the collection and reuse of data, academic medical centers, and fancy academic medical centers in particular, are the places that have the resources to do that kind of thing and, in fact, do that sort of data collection more than anywhere else. And so that's where we see and find lots of data. So it's the easiest place to go. It's not the only place. I'm not arguing that people aren't doing wonderful work collecting data from community health centers. But the easiest place to go is a big academic medical center. And whenever you read about these big partnerships, right, this is Google partnering with the University of Chicago. Or just this morning we mentioned a partnership between 60 leading academic medical centers to collect their data, right? These are the places where we go first. The second set of reasons I think about is basically about branding. Branding and adoption, which is if what you want to do is say, here is this algorithm. It does a great job of recommending care or of diagnosing or of doing whatever it is. We maybe can't tell you exactly how it works because it's opaque, because it's black box, but it does a great job. It is an easier sell if you can say one thing you don't have to worry about is the quality of the data and the quality of the care on which this was trained because it is from a top-notch institution. It is from the University of Michigan, Go Blue, or Memorial Sloan Kettering, or Mass General, or wherever, and that's not a concern. Don't worry about that when you're thinking about adopting our algorithm for your particular context. And then the third set of factors I think about as being basically legal risk mitigation. If you're trying to get past review by the FDA, if you're trying to win reimbursement by insurers, if you're trying to avoid medical malpractice or tort liability, and you're trying to worry about convincing judges or jurors that whatever it was that went wrong, it wasn't the development of your algorithm. In all of those areas of law, it is simply one fewer risk to take if you say, well, we don't have to worry about the quality of the care. We don't have to worry about the source of the data. This is from a fancy place. Jurors, maybe we made a mistake in exactly how we trained. Maybe we made a mistake in our parameters. But look, the data we have are from Harvard. Don't worry about those. And so the law makes it easy to pursue this path and creates additional incentives to say, let's train algorithms in fancy places, in academic medical resource places, in high resource contexts, and then use those algorithms to deploy to other places. This sounds like a convincing story. It sounds all good. But of course, this wouldn't be a law talk unless there were some sort of problem. And you've already heard about lots of the problems, right? The problems occur when you try to translate from one context to the other, and in particular, systematically, when you translate from high resource contexts to low resource contexts. So the biggest type of what I call contextual bias that I think we should see arising here is one that I think hasn't been mentioned as much before, which is in the type of care that's recommended. And the type of care that is best for a patient in a high-resource context may well be substantially different from the type of care that is best for a patient in a low-resource context. Let me give a couple of examples. Well, I'll really focus on one example. Imagine that you have a patient who, a cancer patient, needs a chemotherapeutic. You have an option between two different drugs. One of them is particularly strong, much more likely to have a positive impact in terms of resolving the cancer quickly, but has powerful side effects, and they're hugely problematic, and you need to manage them quite quickly and respond to them rapidly and effectively. The other chemotherapeutic has a lower overall success rate in terms of actually resolving the principal issue, but many fewer side effects, and we're not so worried about it. Now, if you're at Memorial Sloan Kettering and you have a crack team of oncology nurses on call 24/7 available for intervention, that first drug's a pretty good choice because you're pretty sure that you're going to get the outcome that you want and you're not so worried about those side effects because you can deal with them. If, on the other hand, you are at a community hospital or somewhere out in the boonies or somewhere with just many fewer resources, that second drug is looking like a much more attractive choice because you're still going to get hopefully a positive outcome and you don't need to worry anywhere near as much about your inability to cope with those side effects. We can similarly imagine things like a high-touch surgery that's going to require a lot of repeat visits being more appropriate when you're in an urban area or a high-resource center context where you can provide those sorts of resources like St. Jude's does to say, look, we're going to fly you here, we'll keep you around, we'll help you out with all of this stuff, than if you're in a relatively low-resource context. So the things the algorithm learns to recommend may be different and different for good reason if we're just training in this one type of context. The second big issue here is about the patient populations. We've seen some of this before, but the people that show up in academic medical centers are not the same as the people that show up in different medical centers. I'm not suggesting anything about exactly which population is more diverse or less diverse. They're just different populations of folks. And we have wonderful examples of the problematic issues that arise when we train algorithms, when we learn about precision health or precision medicine or whatever we're trying to do from limited populations. The one I like to jump to is hypertrophic cardiomyopathy. Right, this is a disease where the walls of the heart are abnormally thick. The basic way that it shows up is young athletes pass out and or die. That's pretty much the first symptom that you often see. But there's a group that did a great study and found, hey, here's a set of alleles that are highly predictive of this. And, well, it turns out that those alleles are only predictive in white patients, because almost all genetic information that we have, not almost all, but a huge chunk of the genetic information that we have comes from patients of Caucasian descent. And if it's not Caucasian descent, it's typically East Asian descent. And in fact, these alleles were totally non-predictive for African American patients. The last type of bias that I see coming up here is with respect to cost. And this is something we also don't talk about a whole lot. But if one of the goals of medical AI is to make things more efficient and to reduce costs in the system, we would like, at least potentially, for the care that AI recommends not to be incredibly costly care. But if we're looking for cutting-edge, expensive technology, a really good place to look for that is academic medical centers. And so if we train AI in environments that are particularly care-intensive, that are particularly involved with cutting-edge, new, expensive technologies, we should expect the AI to learn and be trained to recommend interventions that are especially costly. So we might worry about that type of contextual bias as well. Okay, so hopefully I've convinced you that this is at least a set of issues, or it's possible that you walked into this talk convinced that these were already a set of issues, and you're just waiting for me to tell you how the law can solve this. And I'm not quite going to tell you how the law can solve this, but I'll at least tell you some ways that we can think about, and I'll start with a couple of ways that the law really can't solve this. A couple of interventions that you might think, oh, like this is a helpful, handy thing to do, but actually is going to be a problem. So the first place I think we leap in this situation is labeling. Right, we say, oh, we develop drugs have problems, but we put labels on them, people know the limitations, that's fine, we're not gonna worry about it. And so why don't we just label algorithms and say, here's where it's trained, here's the type of environment that it works in, go forth and use it where it's appropriate, and don't use it where it's not appropriate. We don't have to worry about this issue. Few problems of increasing severity. The first one is we don't know what to put on the label. If we don't actually know what it is about a particular environment, what it is about a particular patient population that's resulting in this form of bias, then we don't know how to label it appropriately. And we often won't know because we don't have the data in the first place to figure this out. Even if we do label it, turns out doctors really frequently ignore labels. Not ignore them, but off-label use is like a huge thing, right? And there's no reason to expect that if you have drugs that say, here is where this drug was validated, and yet doctors use it a ton of the time in lots of other contexts, we should expect to see pretty similar things in the context of algorithmic medicine, where we say, okay, this is where the algorithm was validated, like we can only be sure about it in a population that happens to be in an urban center in Missouri, and yet people will use it all over the place, because that's what people in health do. So we don't know what to put in labels. If we do have labels, they're probably going to be ignored. But, and this is the kicker, even if we have labels, even if we then have doctors follow the label religiously, we haven't solved our problem. In fact, we've just made it worse. Because think about what the point of this whole exercise is, which is to democratize expertise and to take care that's previously only available in certain relatively rarefied contexts and make it available outside those contexts. And what you've done is put in place a label that says, hey, you should only use this in rarefied contexts like it was developed. We haven't done any good. We haven't actually democratized expertise. We've just said, congratulations, the thing developed at Memorial Sloan Kettering, maybe you can also use it at the Mayo Clinic. But that's not that helpful if what we want to do is transform health for lots and lots and lots of people. The second thing we might think of as a way to solve this issue is doctors in the loop. Right? We might say, hey, yes, sure, there's an issue of contextual bias here, but look, there's a doctor there. We always have problems where, we don't know exactly what's going, but the doctor's there in the room, the doctor can figure things out. Why would the doctor use a recommendation that's a lousy recommendation? How about the doctor? Why won't the human in the loop resolve this issue and make us not worry about it? Again, a set of escalating responses to this. The first is the issue of automation bias or automation complacency that was mentioned earlier, which is that it's really easy to say, oh, the computer told me to do this, I'm just gonna go with it. That happens in lots of fields. There's evidence that it happens in medicine. There's no particular reason to think we shouldn't see the same sort of thing happening here. The second challenge is the more time sensitive it gets in a particular issue or in a particular situation, the less time you have to second guess the algorithm and the less time you're going to say, no, wait, let's take a step back. Let's be sure this is working. The third problem here is if it's the case that the algorithms are actually doing a good job of democratizing expertise, of suggesting good things to do, we don't actually want doctors second-guessing them that much, right? If the doctor gets things right 95% of the time and the AI gets things right 98% of the time, it's actually going to be pretty tough to know which 3% of the time the doctor should defer to the AI versus not. And so if we're overruling all the time that it doesn't agree with whatever the doctor thinks is the right thing to do, we're going to leave that 3% on the table, and that's kind of missing the point. But the last and biggest concern here, and the reason we can't rely on physicians in the loop, again, comes back to the point of what we're doing in the first place, which is democratizing expertise. And often, there won't be an expert in the room. We would like for there always to be an expert in the room, but if what we're doing is saying, hey, here's AI that will let you do things that are otherwise beyond your capacity, you don't have the capacity to figure out whether or not the AI is causing a problem and whether or not the recommendations that the AI is making are appropriate to that particular context. This is, this is mildly an issue when we talk about saying, here's a middle-of-the-road oncologist and we're going to try to help them perform like a top-of-the-line oncologist. It's really, really a problem when you say, here's a layperson in Nigeria, and we're trying to give them the capacity to perform at the same level as a moderately trained physician in Nigeria. Then you really don't have an expert in the loop to try to solve this. Okay, so these are some things we might think of that we might leap to, but don't actually help that much. So how can the law do it? How can the law help? At least I promised you I was going to try to suggest one or two things. So one option here is FDA, right? We haven't mentioned FDA yet today. It's very sad for me. I like to think about how FDA helps regulate medical devices. And to the small number, or the relatively small number of these things that actually go through FDA, because lots of stuff won't, they'll just kind of hang out in the background. The small amount of stuff that goes through FDA, you could imagine an FDA role in saying, no, we really want to make sure that if you are really using this to democratize care, you're doing it right. So to show trials that say, look, we've actually used this in a bunch of different contexts, and we have demonstrated that it works in a bunch of different contexts, and we have the same sort of performance validation, not just internal and not just in places that look like where this was developed. FDA has done this to some extent, which is kind of cool. So the IDXDR platform, which is a camera platform that takes images of the retinal fundus to make a diagnosis, an actual diagnosis, not just some information, of more than mild diabetic retinopathy. Interestingly, different approval patterns. In Europe, this was approved relatively quickly and easily, and there wasn't, you have to use it with this camera system. And the US FDA basically said, look, you have to demonstrate to us that it works in a bunch of different contexts. And the company ended up realizing, if we want that to be the case, we need to say you can only use it with this camera system. Here's the training that happens. You have to use this system. And if you do that, then we're pretty convinced that wherever you apply this, you're going to get the same sort of result. And it turns out it's much easier to deploy it once you've said, this is how we're going to ensure that it's quite generalizable across different contexts. Fun thing, if FDA is the place doing this, that actually also helps deal with some of those other issues I mentioned in terms of insurance and liability and obviously FDA approval. Because FDA approval has been linked to insurer reimbursement, and because FDA approval, at least as a class 3 device, will immunize you from a bunch of state tort liability. So it's kind of fun because if, to the extent FDA gets involved in this, kills a couple birds with one stone here. But FDA is not going to be involved in a lot of these algorithms because they're going to be developed in-house, or they're about predictions, or they're not commercialized, or they're just not particularly about clinical care, and so, or maybe they explain how they work, and so FDA won't be involved. What we'd really like to know is why algorithms might or might not apply well outside the context in which they're developed. And to do that and to figure it out, what we really need is data from lots of contexts. We need the high quality data from not only academic medical centers, but from places that aren't academic medical centers. And so I think the most straightforward intervention here from a policy perspective is an investment in infrastructure for and of data. By infrastructure of data, I mean things like the All of Us cohort that says, yeah, we're going to try to develop a large, high-quality national data set that has a ton of information in it. So if you're training algorithms, you have the right sort of data from a broad swath of people in a broad swath of contexts. And the All of Us cohort is trying to do exactly that. Now, if I had my druthers, I'd make it about 100 times bigger, but they're already having some challenges with recruitment. So I still think pushing in that direction is a good way to go. And the last and frankly unsexiest intervention of all is infrastructure for data, which is just to say, if it's hard right now to capture and make available for secondary use high quality health data, one thing we can try to do is make that less hard by providing things so blasé and boring as grants for IT systems for community health centers, as government support for standards like FHIR and other standards that just make things easier. More useful guidance for implementing HIPAA and taking into account research use. Like, these are very unfun interventions, but if we really want data from lots of different contexts so that we don't run into this issue, so that we don't have that first intervention, which is the data are at places like this and not at places like that, we have to make those data easier to get. We have to collect them more readily and more thoughtfully. I think the big problem that I want to avoid here is the concern that here's this technology that has the potential to be truly transformative in saying, let's take high quality medical care and make it available to people around the globe to help millions, if not billions. And it's so easy, so easy to slip down a path that says what it's actually going to do is make incremental improvements in the places where we already are doing the best in terms of providing healthcare. So I'm going to stop early because I'm curious as to what you think, and I like the conversation part of this. We'll see. Thanks.
Questions, comments, things you'd like to discuss?
For a wonderful presentation. Do you think that there's enough, I guess, going on in this field that it'd be worth having a AI or almost big data specific thing like the FDA? When the Food and Drug Administration came about, because as we started to have a more urban and industrialized food system and medical system, we needed to have that regulatory agency. Is there enough reason to have its own?
Yeah, so a professor named Andrew Tutt wrote a paper called An FDA for Algorithms a little while back. And a couple of other people have made proposals like this to say, should we have some sort of overall regulatory agency which is charged with making sure algorithms work well? And they generally think about this as kind of a cross-sectoral regulator, where we're talking, not just health algorithms, but also whatever else you want, finance and policing and all sorts of things. I tend to be skeptical of proposals like this, largely because I think, one of the lessons that we get from the speakers this morning and from everybody else who kind of worries about this is the extent to which understanding the realities of a system and workflow and context ends up really mattering, and subject matter specific expertise ends up being hugely important, right? The talk this morning about we don't just want to have computer scientists doing this. We need computer scientists partnering with physicians to do this. And FDA has a solid amount of expertise in how do we validate systems for widespread use, or how do we think about doing this at least. So FDA in particular is bulking up its digital health group and trying to work on this. They're, I think, actually kind of out in front of the curve, which is neat. So yeah, I think it's probably going to end up being sector specific enough that that's not likely to be the most useful intervention. The challenge, of course, is even if FDA has a subject matter specific expertise, there are tons and tons of healthcare algorithms that aren't going to go through anything, right? So when Professor Khalija, I'm probably getting that wrong, and I apologize, mentioned the idea of an AI system, every hospital having its own AI system, every practitioner having its own AI system. Part of me thinks, yes, like be contextual, be artisan, be like focused on the needs of every individual institution. And part of me thinks, oh God, no. Like if we have this, then what we're also saying is the validation of every system and the upkeep of every system and the insurance that every system actually is working in every particular place is going to be up to that system, and we're not going to share expertise, so I'm terrified by that kind of outcome. Sorry, I strayed a little far from your question, but I guess I had more things to say.
Great. That was great. Nicholson, thank you so much. Okay, so this is maybe putting a magnifying glass on that thing about the physician at the bedside and the 3%, right? And you've got the AI clicking along, and isn't there going to be someone like that? Okay, so I'm that guy, and I'm a general surgeon, right? And so I'm thinking about like Philip Payne's thing about sepsis prediction, and there are states in the post-operative period that look like sepsis enough to trigger it. So surgeons, I mean, I could put you right there in the Morbidity and Mortality Conference where we were talking about this. They were on fire when they let this thing go because we were clicking through the AI. You know what I mean? Being like, nope, not sepsis. I mean, the classic problem is, surgeon versus nature, right? Now we've got surgeon versus nature and AI. That 3% thing is not just a 3% thing, but it's also like this complacency. You know what I mean? Like AI is crap. It doesn't understand surgery. I'm not using it. I'm just going to click through. I'm just going to default towards clicking through. I mean, I don't know. What do you think about that? What am I supposed to do? Click through it or think about it?
Wait, when you say click through, do you mean agree or disagree?
Disagree. It's not sepsis. It's not sepsis. I'm going to keep treating the patient the post-operative way they know how. And I'm not going to treat them for sepsis. But there's legal stuff there, right? Because, then if the patient dies or something, whatever, they're going to say, well, the computer told you it was sepsis.
Yeah, so I actually had a paper about this just 2 weeks ago talking about liability for physicians using AI. And there's a result, I think, the way the law pushes is a way that I think is sad if you're thinking about the law. If you're thinking about the law as a way to try to encourage positive change, but relaxing if you're a physician, which is to say, and if the AI says do X, and you think, well, the standard thing that we do is Y, and like I'm a physician, I know what I'm doing. This is what physicians in my community do, and it's Y, and you do Y, and you ignore the AI, and it turns out the AI was totally right all along. From a legal perspective, you're probably fine. Like, if what you do is follow standard practice, even if it's wrong from a liability standpoint, like, you're okay. And that doesn't do a lot in terms of saying, yes, you have to learn to follow this new technology will help. Like, medical malpractice law is not a great way to encourage the adoption of new technologies. Now, again, from a physician point of view, if you just want to click through, you're going to be okay for a long time. Eventually, maybe we'll enter a world where we say the use of AI is part of the standard of care, and if you're not using AI, you're falling below what a physician should do, but we're so far from that.
It's going to get better and better.
Right, well, and that's the thing. Like, we hope, the point of all of this is to say, no, really, AI is going to get better. It's going to help you out. And so law doesn't help with that a whole lot. Now, one thing I'll point out is the initial issue, like the training and now, when you clicking through and say, oh, it's wrong, you're probably right? Because we're just developing the technology, and it's going to be wrong a ton of the time. When we get to a situation where AI is doing better overall, the weird thing is we're still going to have a bunch of situations, like where AI makes mistakes, some of those mistakes are going to be obviously mistakes to the human. And some of the mistakes that humans make are going to be obviously mistakes to AI and almost impenetrable to humans. The best description I heard of this was, if you think of AI like an intelligence, which you shouldn't, but if you think of it like an intelligence, you shouldn't think about it like an artificial human mind, you should think about it like an alien. Which is to say, some things that are just blindingly obvious to you are totally baffling to it, and vice versa. And so the mistakes that people make are going to be, and machines make, are going to be totally different mistakes. And Like, that's hard to deal with. If you have an expert in the room, there's a different situation than in what I think is going to be a lot of situations where there's really not an expert in the room.
Okay, thanks.
Sorry, I shouldn't be
Julie.
calling on them. You
Yes.
should be
No,
calling
you
them.
can.
I'm so sorry. I don't mean to.
It's fine.
This
Take
is
your
kind of
pick.
This is a follow-on question, I think, to the discussion that was just going. I'm Dave Castanero with Prepare AI. So my question is, I think a lot of people will jump to, when they think about AI being applied in a medical and healthcare context, they jump right to, oh, it's going to be making the decision. And so I love hearing I think the informed and more realistic discussion around, okay, it's assisting. And so we don't want it to just be a suggestion or an alert that the doctor is going to click through and ignore, and there's just going to be AI suggestion fatigue. So I guess how do we get to that point? Isn't there some precedent and some familiarity with collaborating physicians? Like if you get a second opinion, you're talking to your colleagues and you ping them, and hey, how does this go? Isn't there some precedent to fall back on? Have you seen people applying AI in like a teamwork approach, and like not just one algorithm, maybe there's 3 or 4 and they have diverse opinions. They help to make it teamwork makes the dream work, like have you seen any of that going on?
Yeah, so this is what I find most interesting is that this, I think, is the default conversation, frankly. The default sophisticated conversation, because the base level is like, oh, AI is going to do all the care. We're going to have Dr. Watson making all the decisions, and humans, oh my God, like radiologists aren't going to have a job because AI will do all the things. And I think most people that are involved in the field say, like, no, that's not going to happen. We're still going to have radiologists are still going to have jobs. And then we think kind of, okay, how do AI and human doctors interact? The thing that I find most interesting about this is, yes, those are fascinating, important conversations to have, but they also come from a place of pretty profound medical privilege, which again is to say, like, we expect that, I assume the vast majority of folks in this room have that sort of medical privilege, and you can say, I am going to go to see a competent specialist if I need one. And so you're asking the question, like when I think about this at Michigan, I think like if I were to have some serious disease and I were to go into the University of Michigan Medical Center and talk to a physician who had the AI next to her, like how would she interact with that? How would she manage her expertise against its expertise? And like, how does that happen? But right, the vast majority of people aren't going to that kind of context. And so, yes, it's an important question to say, how does teamwork make the dream work? But it's also an important question to say, how do we make sure AI works so that when it's the only eye in the team, then like it's still going to work at least well enough to be helpful and not actively harmful.
Okay, having been through a misdiagnosis and had a life-threatening issue, my thoughts on, will AI, okay, let me start with the thought that AI is more of a enhancement to our knowledge. I forget the quote, that was amazing, but it helps the intellectual make a better decision. And the fact to enhance the provider care and human relationship, restoring that, and minimizing misdiagnosis and error. I feel, and with the expansion of plain language movement, do you feel like AI, I feel like what it should be doing is, and I'm wondering if this is happening, is bringing part of the co-diagnosis. So you're passing on a lot of information so that the patient's making their decision with you versus because they have access to information as well, and they have access to take that for a second opinion, so that if they have, until there's one big model that this hospital uses this model and I go get it, if I'm not comfortable, I have all the data you gave me, I go to them, and then I hear theirs, I can feel more comfortable making an educated decision. And then also I think that would limit the risk, but I'm just curious.
Yeah, so I think, I really like the way Eric Topol thinks about this issue, which is to say, there are a lot of things that we ask doctors to do. And it turns out some of them are, we ask doctors to do them now because that's the best way we have to do them, right? Like diagnosis, I'm going to look at a bunch of information and I'm going to do some pattern recognition based on an extensive body of information that I have received over years of medical school and years of practice. And I'm going to say like, okay, like here's my pattern recognition at work. It's this. That's actually not like a great task for humans to be doing long term. It's the best we've got now, but that's a really great task for AI to do. Like that's a terrific task for AI to do. Turns out what AI is really bad at is saying, oh, you're a person, right? Like you're a person who thinks things and believes things and wants things as a person. And we should take into account that person when we're thinking about what the right care pathway is. And like the path of medicine in recent decades has been doing more of the former and less of the latter as you get squeezed in time. And the cool thing about AI is the potential to profoundly shift this and take some of these things that really it's super dumb to have doctors spend a lot of time doing, like the menial stuff, the automating drudgery certainly, but also the things that just machines are going to be really good at and doctors aren't going to be better at, and just take that mostly off the plate. And say, no, what's really important is this is a conversation between two human beings in the room. And yeah, there's a machine that's given us some really useful information, but those human decisions are what AI can allow the space to have happen.
I actually have a question that's sort of picking up on a thread that I'm hearing in your talk and also some of the other comments, and that's the question of contestability. You know, in some ways, the idea of bias is an old idea that's present before AI. Who is in medical trials?
Right.
You know, what kind of data has been collected? So it's not new, but it's different in certain ways with the advent of AI. And one reason is if you think about contesting information prior to AI, you think about going to the medical literature, which is peer-reviewed, you know what the methods are, you could repeat it or challenge it. That's not necessarily present with AI. So thinking about if you were a physician and you got this recommendation and you felt like it was wrong, or you're a patient and you're evaluating this, or you're in a team and AI is participating by giving you a result to talk about, on what basis would you challenge it? And what kind of work is being done around that? Because you'd have to know what the data was and how it used it. And that may be not known, and in fact, it may be not knowable.
Yeah, so I think the things that are easier to know are the procedural stuff. Like how did I collect my data set? How did I do my validation? How do I make sure that this works in different contexts, blah, 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 all of those kind of things. And those are contestable. But the heart of a lot of these algorithms is going to be fundamentally, like especially if we're talking deep learning and like hidden layers in neural networks, it's going to be hard to know how the AI is making the decision. And you're totally right. That type of contest, like how do you argue with the black box on its reasoning if you have no idea how it makes the decision? And it's incredibly hard to figure out what to do. And I don't have a good answer to that. I think the procedural place is a good way to go. I think that fundamentally kind of validation on populations is going to be useful, but the challenge is, of course, you're validating on a population, but you're treating a single patient.
Right.
And contestability is a huge lift. And I don't have a great answer for it.
And it's hard to insert other information like goals, patient goals, history, values.
Yep.
That's only going to be on one side.
Right.
That's
Totally
something
true.
only the physician will know in conversation with the patient. It's actually not possible for AI to know that on an individual level.
Totally agreed. That is a wildly dissatisfying note on which to end. But I think we are, in fact, at time. Sorry. Dang,
No, I think we are.
Usurping your role.
Yeah.
All right. Well, thank you.
Thanks.
Wow, that's delightful. This is